Committee, my top priority is keeping our promises to older Americans and to Americans with disabilities. We owe it to every older adult, every person with a disability, and their families to have the necessary information to decide when, where, and how to receive care as they age. That has motivated my advocacy, for example, for home and community-based services. Every American who wants to receive care at home should be able to do so, and the workers providing that care must be paid, in my judgment, a living wage. It has similarly motivated my work to ensure that nursing homes are providing safe, quality care for all of their residents. We need to address the chronic underfunding and understaffing for the state agencies that conduct nursing home oversight so they can effectively protect the health and safety of residents. And this core mission of the Aging Committee brings us to today's topic, the topic of assisted living and that landscape. It's been 20 years since this committee held a hearing on assisted living. With the dramatic growth of the assisted living industry in recent decades, it is long past time for Congress to re-examine this model and ensure that it's meeting our nation's needs. The best estimates reveal that nearly 1 million Americans live in more than 30,000 assisted living facilities across our nation, and that is almost certainly an undercount of that number. Assisted living facilities are state-regulated residences that support assisted living while offering help with the activities of daily living, like bathing and medication management. They also often provide meaningful engagement and activities for their residents. Assisted living was first envisioned as a social model for residents who needed lower levels of support. But today, people living in assisted living facilities are older, require more care, and have health care needs similar to that of those who reside in a nursing home. And the needs of the assisted living population change. As those needs change, we need to know that if assisted living facilities are meeting the needs of those residents or the needs of their families. One major issue I hear a lot about is cost. Assisted living facilities are widely unaffordable to the average American and their family. A recent survey found that 80% of older adults would be unable to afford 4 years in an assisted living facility. The average annual cost is $54,000 a year, but the costs can be substantially higher depending upon the location and the type of care that a resident requires. The more assistance and care a resident needs, the more they pay. And in some cases, residents and their families don't know the total cost until they receive their monthly bill. These substantial costs and often hidden fees make it nearly impossible for older adults and their families to accurately budget for long-term care. Now, that's one of the reasons why I'm starting today. I'm asking Pennsylvanians and people across the country to share their stories and their bills with us. I want to hear from you about the true cost of assisted living and understand whether families have the information that they need to make difficult financial and healthcare decisions. I'm just going to hold up the website address for those who need it. You can go to aging.senate.gov/assisted living bills, all one word, assisted living bills, to share your stories. I think it's very important that we hear from people about their own experience as family members, as people who are paying the bill, and also expecting the promises that are made when someone becomes a resident of an assisted living facility. It is only by hearing those stories, only by hearing about those experiences, can we bring the needed change that I know we all agree has to come. The assisted living industry is also facing the same workforce crisis that we see across other long-term care settings and even beyond long-term care. It's also true in the context of child care and so many other parts of our healthcare and care landscape. Workers are often struggling to support their own families because direct care workers are paid an average of just $15 an hour nationwide. Workers provide a higher level of care to support residents' growing needs, especially residents with dementia. But training requirements and worker support look very different in each state. As we'll hear from our witnesses, these challenges make it harder for families to find the information that they need about assisted living facilities, including how much it will cost, the quality of the services they receive, and how safe their family member will be. A recent Washington Post investigation found that since 2018, more than 2,000 people have left assisted living facilities unsupervised and have been left unattended outside. Tragically, 98 of these 200 or 2,000 incidents have resulted in the death of the resident. And those are just the cases that have been reported. The findings of the Post investigation demonstrate how urgent it is that Congress better understand this industry. There's also been significant reporting by the New York Times and KFF in a series written before the end of last year. To help in our understanding, I've sent letters to 3 of the largest corporate owners of America's assisted living facilities. These letters request information about costs, workforce, safety, and availability of information about quality and services in assisted living facilities. I hope these letters, or I should say the response to the letters, will improve transparency in the assisted living industry and help to inform policy solutions to address some of these concerns. As families are making difficult decisions about where to age, they deserve to know that their loved ones are safe. I think we can all agree on that. And assisted living providers making promises they cannot keep is a violation of trust. As we continue to increase the quality of the continuum of long-term care for older adults, it is time we prioritize efforts to improve the assisted living care option. If we say we're, as a nation, the United States, the greatest country in the world, then we have to have the best, not second, not third, the best long-term care in the world, and we're not there yet. Older adults and people with disabilities who call assisted living facilities home, we have to remember this is their home, their residence, where they live, where their families come to see them. If those older adults and people with disabilities are calling those facilities home, they should have quality, affordable care. So I look forward to hearing from our witnesses today, and I'll turn to Ranking Member Braun for his opening statement.
Thank you, Chairman Casey. In 2050, you think the problem is bad now, 1 in 4 Americans will be 65 years of age or older. With an aging population that we know is coming at us, thank goodness we have hearings like this to highlight what you're going to do about it. Sometimes the market doesn't do the job. I do want to say that ideally these things are crafted through the market and probably with states leading the way. And I say that for one big reason. I'm on the budget committee. And the biggest thing that challenges this place is how you would add something even further to the list of things you want to do when we're now borrowing $1 trillion every 6 months instead of annually. And that's just changed over the last 5 years. So we have to be careful. But it still has nothing to do with a problem or an issue that's out there. And this is about highlighting who can do it best and how you get there. Chronic workforce shortage. When I travel, visit all 92 counties in Indiana, pre-COVID, that was the #1 issue. And it's about double now the number of jobs in my own state. I think it's close to 130,000. It was 65,000. And caregivers, large percentage of whom are that assistance is given by independent contractors, small business owners. We need to figure out how to enable that, make it easier, how you actually have your curriculums in various states and school systems that show the full spectrum of what jobs are out there and where the needs are. So Senator Kane and I introduced the Jobs Act here, which allows students to use federal Pell Grants for high-quality, short-term job training programs. That's a good federal program. It's not adding much to it. It's increasing the flexibility of how you can use it. Senators Rosen, Collins, and I also introduced the Train More Nurses Act, which reviews all nursing grant programs to find ways of increasing nursing pathways. Happy to hear some things do work well here. That passed, I think, by unanimous consent last night in the U.S. Senate. So now we got to get it over to the House to do the same thing. The federal government should make it easier for people to enter the healthcare workforce and for families to take care of their loved ones by making sure that it's energizing the people that may be interested in it and in the places that are going to probably be doing the heavy lifting. Right now, for instance, the Biden administration is saying one thing and actually doing another. And it happens to do with, I come from the world of small business, independent contractors, retailers, individuals that make their living out of maybe running a small business. The independent contractor rule that is out there, which would make that more difficult, could eliminate many of the existing caregiver jobs for that reason. So you got to make sure you're not wanting to do something and then you're working at a cross purpose through another agency that'll make it even more difficult. Unlike nursing homes that are regulated by both federal and state agencies, assisted living facilities are primarily regulated by states. To increase safety and transparency, Indiana requires staffing ratios, dementia training, and maintains a website that discloses reports and enforcement actions. States and assisted living facilities are also working to find creative ways to use existing resources to assist seniors. Indiana is using a combination of state and federal tools to provide more affordable assisted living to Hoosiers. As a result, Indiana has seen affordability and quality improve. However, there's always more work to be done. Some of my colleagues may be tempted to call for a shift towards increased federal involvement and regulation. I'd say be careful. Help us get best practices out there. Help us have an environment to get it done where it's normally done more effectively, more affordably at lower levels of government. I believe that states are best positioned to meet that growing need. I'm glad we here at the federal level, this is the big microphone that has to highlight the issues. That's what we're doing here today. Thank you all the panelists for being here, and I'm interested to see what we can come up with. Thank you, Mr. Chairman.
Thank you, Ranking Member Braun. We'll next turn to our witness introductions. I'm grateful for the time and the work that goes into an appearance by our witnesses. Our first witness this morning is Ms. Patty Vessenmeyer from Gainesville, Virginia. Her first husband, John Whitney, had dementia and lived in an assisted living facility at the end of his life. She will share some of her and her husband's experiences where she supported him in an assisted living setting. So, Patty, we're grateful you're here today. Thank you. Our second witness is Dr. Jennifer Kraft Morgan. And Dr. Morgan is from Waleska, Georgia. Dr. Morgan is a professor and director of the Gerontology Institute at Georgia State University. She studies issues related to long-term care dementia in the healthcare workforce. Thanks for being with us today, Doctor. Our third witness is Dr. Julie Simpkins, and I'll turn to Ranking Member Braun for that introduction.
Julie Simpkins is the co-president of Guardant Management Systems. She's been in the long-term care arena for nearly 30 years. Ms. Simpkins focuses on affordable assisted living, and she advocates for both providers and older Americans and gardens 82 facilities across the country. She leads on several state and national associations, including the Indiana Healthcare Association Board of Directors and the National Center for Assisted Living Board of Directors. Thank you for testifying here today.
Thank you, Ranking Member Braun. Our fourth and final witness is Richard Millett. He is the Executive Director of the Long-Term Care Community Coalition. This coalition works to provide families with unbiased information about nursing homes, assisted living facilities, and other long-term care settings. Thanks for being with us today. And we'll turn to our first witness, Patty Vessenmeyer.
Good morning, Chairman Casey, Ranking Member Braun, and members of the Senate Special Committee on Aging. My name is Patty Vessenmeyer, and thank you for allowing me to share this testimony of my experience with assisted living for my husband, John Whitney, during his journey through the middle stage of dementia. I will focus on my experiences and observations that I believe are most relevant to your national focus. In 2013, my husband was diagnosed with dementia with Lewy bodies. Although this dementia is similar to Alzheimer's, it manifests itself a bit differently, and it is important that caregivers be informed and trained appropriately to ensure the comfort, safety, and security of their patients. Some key symptoms are loss of sense of smell, REM sleep behavior disorder, which causes individuals to violently act out dreams, often falling out of bed, visual hallucinations, marked fluctuations in attention and alertness, and gastrointestinal issues, including severe constipation, all of which my husband experienced. Loss of memory often occurs much later in this disease process. I took several free courses on caregiving for individuals with dementia, including a virtual reality dementia experience, which helped me to understand the challenges that people with this disorder face, and most importantly, why they become fearful and combative. I mention this to provide a basis for my ability to recognize problems with care as I saw it. These same courses are offered for professionals at reasonable costs. In June of 2017, when my husband's disease was progressing more rapidly, I moved to Virginia to be near family. I cared for him alone at home until January 26, 2018, when he attempted to strangle me in my bed. The state determined that John should be placed in a long-term care facility. I found him a room in an assisted living facility in Warrenton, Virginia, that specialized in memory care. He moved in the first week of March in 2018. I provided the management team with John's history, his diagnosis, and disease progression. The following is a list of issues that I observed in the memory care unit during my daily visits with John. Poor facility design. There were blocks of rooms built around a large central room for group activities and TV. The central room was extremely loud, and high levels of noise can easily agitate dementia patients. Activity stations were set up for residents. One of these had various lengths of PVC pipe. Not kidding. Some longer than a baseball bat. These were weapons in waiting, and you can guess what happened. There was no quiet area for the residents other than their rooms. The hallways and the room blocks were isolated, making it difficult for staff to monitor. There were many incidents that I witnessed when there were no staff around. I will share one that I feel was very important. A woman fell by tripping on a raised area on the floor where the rug abutted the hard flooring. Nobody saw her fall. I found her bloody and staggering down a hallway. A company knowledgeable about dementia care would not design a facility this way. They would certainly understand that people with dementia have problems with gait and balance. And do understand there were video cameras in place, but they only used them for reviewing incidents after the fact. They were understaffed. Too many patients were assigned to each caregiver. In the morning, each caregiver needed to give their assigned residents, get them up and dressed and ready for breakfast. Everybody ate at the same time, putting additional pressure on the staff. They only gave residents a shower when necessary as they were always pressed for time. Caregivers needed extra time to spend on residents in more advanced stages of dementia, as they required help to move from their bed to a wheelchair and be hand-fed. After lunch, the caregivers would place most of the resident in chairs in the main room while they worked getting the advanced stage patients back into their beds. Every day after lunch, my husband urgently needed to empty his bowels. Several times when I was there, I tried to help him, but it was difficult for me as I had had a broken arm at the time. I could not find anybody, so I did the best I could. And often when I was not there, he soiled himself while waiting for help. I once believe I saved a man's life. I was with my husband in a room off the main activity area. I heard someone crying for help. I ran into the hallway and found an old man on the floor trying to protect himself from being beaten with his own cane by another resident. I called for help, quickly moving closer and redirecting the attacker's attention. I kept him busy while calmly calling for assistance, trying not to further agitate him. It took several minutes before a staff member finally heard me and came to help. Night was no better, as staff levels were lower as allowed by state regulations. They placed residents who had trouble sleeping in front of a TV while they dealt with other residents. Inadequate staff training. Most of their caregiver staff were trained as nurses' aides, but nothing specific to memory care that I could see. I witnessed them providing new hires dementia training care in a conference room. This consisted of a member of the management team showing them parts of Glenn Campbell's I'll Be Me movie and pointing out some behaviors that demonstrated his dementia problems. I saw that movie, and it was not appropriate for training purposes. I observed several instances where caregivers and nurses displayed limited knowledge of working with dementia patients, particularly those in mid-stage of the disease who became more fearful and combative. Some examples: nurses running towards a patient, causing the resident to become combative. Quick, erratic hand movements, frightening the individual. And another example on TV was on at 9:30 p.m. with extremely high volume. Several residents were seated in chairs and wheelchairs in front of the TV. Anyone who understands dementia and sundowning would never do this. They were overstimulating these residents instead of allowing them to relax and quiet their minds for sleep. And finally, at one point, the director of the facility told me to spend less time there and let them do their jobs. Well, I could not abide because I felt they weren't doing their jobs. In closing, unless things change, I could never recommend using this type of facility for a loved one unless things improve. I'm hoping that you found my testimony helpful and that the committee will find a way to set some national standards for appropriate levels of staffing and training for that staff. This would be a huge step in improving assisted living. Thank you for your time.
Thank you very much, Ms. Vesemeyer. I appreciate your testimony. Dr. Morgan.
Good morning, Chairman Casey, Ranking Member Braun, and the members of the committee. I'm honored and delighted to be here. Thank you, Patty, for sharing that story. Assisted living is a large and growing long-term care residential option for individuals who need or want additional supports for activities of daily living. There are approximately 30,600 AL communities in the U.S., with approximately 820,000 residents employing about 500,000 workers. AL, often seen by the public as interchangeable with skilled nursing homes, was built and is regulated as a social model of care. This community-based care is less restrictive and strives to be home-like. AL residents vary greatly in the amount of care they need from person to person. Rising acuity levels do mean that as residents age in place, they likely require more health services. While these services could overlay AL services, much like they would if the person was needing care was at home, these are not provided directly by the AL communities. The haphazard growth of this model and the tensions between social care and health care inherent have spurred calls by scholars for assisted living to be reimagined. Most AL residents need help with medications, and more than half need help with 3 or more activities of daily living. AL residents depend on their care networks, the constellation of kin and non-kin involved in residents' lives, to arrange medical care, to provide social support, to coordinate care, to engage residents in activities, and bring needed supplies. These care works also play an important role in advocating for residents and negotiating care with AL staff. About 42% of AL residents have a dementia diagnosis, but we can assume this is underreported, as many older adults are not screened, tested, or diagnosed with dementia despite showing simple symptoms in memory, thinking, or making decisions that impact everyday life. Like all people with chronic disease, people living with dementia have good days and bad days. Person-centered dementia care is needed to tailor care and support to individuals in ways that account for preferences, life experiences, communication styles, and support needs that change over time. According to NCAL, the average monthly cost of AL is $4,500. As such, AL is inaccessible to most Americans. Yet on the spectrum of long-term care, it's often needed. Seen as a step between unpaid care by loved ones and nursing home care, AL provides a very important long-term care option. When the care needs of a loved one exceeds the capacity of their care network, the person and their care network is forced to navigate, with little support or education, a variety of options, none of which are usually covered by health insurance. If they have significant financial resources, AL is a useful and attractive option. If not, managing the care situation means that care partners reduce working hours, build precarious care or financial arrangements across families, hire piecemeal personal care support, or simply cross their fingers and hope that it all works out. 66% of the AL workforce are aides or direct care workers. Direct care workers in AL and across long-term care are predominantly women, people of color, and disproportionately immigrants. The typical direct care worker, as Senator Casey said, makes about $15 an hour, works 36 hours a week in assisted living, and works for a for-profit company. AL workers, like most direct care workers, tend to go into this line of work to give back, to make a difference, because they value elders or because it's a calling for them. Unfortunately, the system we've set up works against them. Direct care workers in long-term care settings experience low wages, few benefits, heavy workloads, dangerous jobs, and little to no career mobility. In her book, Disrupting the Status Quo of Senior Living, a Mind Shift, Jill Vitale Awesome lays out what I think is the crux of the problems facing senior living. AL is marketed to those who can afford it with a hospitality mindset. They advertise and compete on the basis of beautiful campuses, luxury food and furnishings, and concierge services. This model encourages residents and families to think about this next step as though they're going to a hotel or a resort. This framing, where residents are guests and staff are encouraged to cater to their whims, increases what Dr. Bill Thomas of the Eden Alternative calls the 3 plagues of long-term care: helplessness, boredom, and loneliness. By encouraging passivity, we leave residents with few opportunities for giving back or creative pursuits. Instead, long-term care that is person-centered, community-minded, and empowering for residents, staff, and care partners has a much better chance of success. My recommendations include improve and standardize initial and continuing education training for direct care workers and all staff in assisted living. Professionalize the direct care workforce. Incentivize and reward good employers who deliver high-quality care. Increase access to assisted living. Improve care coordination and resources for people living with dementia and their care partners. And support standardization of monitoring and resources to increase state-based oversight and transparency. Thank you.
Thank you, Doctor, very much for your testimony. Ms. Simpkins, you may begin.
Thank you. Chairman Casey, Ranking Member Braun, and members of the U.S. Senate Special Committee on Aging, thank you for inviting me here today to be part of this important discussion on assisted living, a topic that is very near to my heart. My name is Julie Simpkins, and I'm the co-president of Garden Management Solutions. We're a provider that develops and operates senior living, assisted living, and memory care communities. We are the 5th largest assisted living provider in the country and have communities in 5 states: Illinois, Indiana, Ohio, Maryland, and West Virginia. I have dedicated most of my life to senior living, with over 30 years to the assisted living sector. This is my calling, and I'd like to speak with you today about Garden's unique model as we share thoughts on how we can work together on important issues facing those who need and work in assisted living. Garden is uniquely focused on offering affordable assisted living to low-income seniors. Our company was founded in 1999 after the creation of the Illinois Supportive Living Program, which is a home and community-based waiver program. Now, as we expanded into 4 other states, our commitment to serving this population remains. Many residents living in garden communities rely on Medicaid for their assisted living care through these waiver programs. Garden has been limited in where we can offer our services due to the variability with state Medicaid waiver programs. It depends on the availability of state programs, of state reimbursement levels, and the number of available waiver spots. Offering affordable assisted living exclusively, or even for a majority of residents like Garden, requires an entirely different business model altogether. We've had to persistently seek out HUD loans and income tax credits to stay viable. Therefore, we support efforts to make long-term care, including assisted living, more affordable to low and middle-income individuals. With a rapidly growing elderly population, we need a public and private partnership to incentivize more providers to develop these models. When we talk about assisted living, it's important to note that every state, every community, and every resident is different. Efforts to standardize all assisted living communities would be both unworkable and irresponsible for resident care. State regulations appropriately recognize the diversity within assisted living while holding our profession accountable, and they are consistently updated to reflect the evolving nature of our sector and our residents. Meanwhile, Garden is committed to exceeding the state requirements when we believe it is in the best interest of our residents. We'll take memory care as an example, and something that is top of mind for this committee, as well as our residents and family. Every staff member at Garden's memory care communities receive education and training in dementia-related diseases, as well as training as a certified dementia practitioner. While elopements are rare, we over-report to the state immediately, even something as technical as a resident walking out the door, instantly returning with a staff member. We know they didn't leave our community, and our staff immediately addressed the situation, but we still report it. The recent reports of resident elopements that were ultimately fatal are heartbreaking, and my thoughts and prayers go out to the loved ones of those residents. I serve in leadership positions on numerous national organizations dedicated to long-term care, and I know these tragic incidents are extremely rare and not indicative of the assisted living experience. The overwhelming majority of families and residents have a life-affirming, safe experience. Assisted living providers are committed to upholding our policies and procedures, as well as continuing to learn all that we can about dementia care to prevent these incidents. It is critical that policies and regulations help protect residents while still supporting their freedom of movement and independence. Assisted living is a critical aspect of the long-term care continuum and dedicated to delivering person-centered care to our nation's seniors. We need collaborative, comprehensive solutions that ensure our ability as assisted living communities to continue doing what we do best, providing safe, quality care to our residents. From expanding more affordable long-term care options to workforce programs to addressing the growing caregiver shortages, these efforts could make a real difference. We must all work together to ensure current and future assisted living resident is seen, safe, and served to enjoy the highest quality of life possible. Thank you for your time, and I look forward to answering your questions today.
Thank you, Ms. Simpkins, for your testimony, and we'll turn to our fourth and final witness, Mr. Mollett.
Good morning, Chairman Casey, Ranking Member Braun, and members of the committee. Thank you for inviting me to testify today on this important issue. My name is Richard Mollett, and I'm the Executive Director of the Long-Term Care Community Coalition. LTCCC is a national, nonprofit, nonpartisan organization dedicated to improving care and quality of life for residents in nursing homes and assisted living. We conduct research on long-term care policies and the extent to which essential standards of care are realized in the lives of residents who are typically elderly and frail. In addition to conducting analysis and advocacy, we educate and engage residents, families, and those who work with them so that they are aware of their rights and are equipped to overcome the challenges that so many of our seniors face when they need residential care. Our interest in assisted living is longstanding, and we appreciate your commitment to ensuring that the promise of assisted living is realized in the lives of our growing senior population. Assisted living emerged in the 1980s as an alternate to nursing homes for seniors who want or need to live in a congregated setting where they can get help with tasks like housekeeping, meal preparation, and access to activities and transportation. Over the last 40 years, 3 developments have drastically changed the nature and character of the assisted living sector with both positive and negative implications. They are, 1, the needs and frailty of assisted living residents have dramatically increased. 2, assisted living operators have adopted increasingly sophisticated and large-scale corporate models, including ownership by real estate investment trusts, private equity, and other sophisticated private investment structures. And 3, public payment for and government interest in assisted living has increased significantly. Assisted living facilities now care for people who, in many ways, have the same needs and vulnerabilities as nursing home residents. Assisted living residents are actually older on average than those in nursing homes. Approximately 40 to 70% of assisted living residents have Alzheimer's disease or some other cognitive impairment. Over half have hypertension. 1/3 or more have heart disease or depression. About half need help with dressing and or walking, and 2/3 need help with bathing. Over 10% of residents with dementia receive antipsychotic drugs. Unfortunately, we as a country have failed to keep up with these trends. While some assisted living can be wonderful places to live and to work, too many take in or retain residents for whom they are unable to provide safe care and dignified living conditions. Too many residents and families are at risk for financial exploitation and even fraud. Too many seniors and families get taken in by promises of quote-unquote memory care and aging in place when, in fact, these are more often marketing terms than accurate representations of specialized care. The absence of any federal quality or safety standards, coupled with the virtual absence of reliable public information on the quality, safety, and costs of assisted living, have made assisted living a sector ripe for investment by sophisticated private enterprises who can shuffle around resources and take profits with little regard for the promises made to seniors and their family. These problems occur at every economic level, from $50,000 a month or more paid to luxury assisted living to the 20% of seniors who access assisted living through public funds like Medicaid waivers. It doesn't have to be this way. 40 years ago, when nursing homes were in crisis, Congress took action. From numerous GAO reports to the growing chorus of local and national news reports of neglect, disastrous quote-unquote elopement, and financial shenanigans, it is clear that we have reached that point now with assisted living. We recommend 3 things. 1, establish and implement national standards to promote quality, safety, and integrity in assisted living. 2, establish a national assisted living database with information and metrics that the public needs to evaluate both costs and quality. And 3, promote resident and family engagement to ensure that assisted living is truly a home and community-based service. As I mentioned earlier, assisted living experiences can range from positive to alarming, posing potential risks and exploitation. I think that we can all agree that the lives of seniors should not be left to chance, ambiguity, and insecurity. Thank you again for inviting me to testify today.
Thanks very much for your testimony, and I'll begin the first round of questions, but I want to note for the record, we have senators that are in and out because Thursday is a pretty busy hearing morning, and so we'll have senators, some here, some will be here and then ask questions, and folks will be appearing intermittently throughout the hearing, but so far, I know that Senator Rick Scott was here and Senator Blumenthal was here, and we'll be awaiting others after my questions and those of the ranking member. But I wanted to start with you, Patty Vessenmeyer, about your own experience, and I want to start by saying how much I appreciate, and know the committee appreciates, your willingness to share a personal story. That happens in hearings like this on a pretty regular basis, where an individual comes forward and talks about their own experience or that of their family. And from a distance, it might seem easy, but I can't imagine how difficult it is to recount difficult, painful moments, and doing it in the interest, of course, of helping others. So we're grateful for your willingness to do that, and telling your story is a very important part of the work we're trying to do together. I know that your husband was in an assisted living facility, and you were, as you indicated, paying privately for those services to make sure that he would get the care that he needed for dementia. And I know I've heard from my own constituents back home similar stories. For example, Angela, who's a constituent of mine from Johnstown, Pennsylvania, Cambria County, out in the southwestern region of our state, she wrote to me and said that her father was in one facility that charged $7,200 a month. Now, I know that's not the average. It's very high. That works out to about $90,000 a year. And Angela shared, and I'm quoting her here, quote, "There was always a sense that no one cared for the residents beyond their monthly payments," unquote. That's one experience, and that's one person's personal experience. But Ms. Vessenmeyer, I wanted to ask, based upon your experience with your husband, did the facilities he lived in deliver on the care that they promised to provide?
Thank you, Senator. Thank you for appreciating me coming and doing this. And I think the good news is it's been 6 years and I'm able to do it without getting overly emotional. No, they did not deliver. They definitely overpromised. And understand that they were absolutely a memory care facility, specialized in it, and knew what they were doing. His basic needs were not often met. You could hear through some of the examples that I gave. And I observed other people the same way. They would actually recommend that you pay an additional private caregiver to come in to give them the care they really should have gotten, but their staff was there just wasn't enough staff for them to get it done. And do understand that their staff was friendly and caring, and they were wonderful people who weren't trained, and they were just overwhelmed. But they definitely did not deliver. And by the way, it did come out of my pocket because my husband had chosen not to do long care insurance. And that number that the woman gave you was low. That was my starting figure, was $7,900. It cost me closer to $13,000 a month.
We're grateful for you sharing your own story, your own experience. And I wanted to next turn to Richard Mollett. You mentioned a need for more substantive and meaningful ways for residents who might choose a particular facility or their families to know which services they receive, how much those services cost, the outcomes for residents living in a specific assisted living facility. For a family searching for care, and we hear about this all the time, I'm not sure doubt there's anyone in this room who doesn't know someone who's had the experience of having to search for care and to try to navigate it. It's obviously difficult to find the information that folks need about assisted living facilities. And sometimes they only have the word of an assisted living provider, or maybe someone else who's had their own experience they can rely upon. Can you elaborate more on the challenges that families have in finding both accurate information and unbiased information about services, about costs, about care outcomes for residents in assisted living facilities?
Thank you. So essentially, there's no independent validated information on assisted living for the consumers, for policymakers, or for the general public. So families, as you noted, have to rely on facilities, on facility marketing materials. They also quite often rely on companies like A Place for Mom and other so-called consumer resources, that are not independent of the industry. Companies like Caring.com and Place for Mom that actually get money from facilities to be listed. So that's not independent either. That's not something that people can rely on as being necessarily an accurate information of what has happened, what they're going to pay for, and what they're going to get. And the state websites really are the last resource, and they tend to be very flimsy. I haven't looked at every single one, but the ones
tend
that
to be, you
very
said
flimsy. I'm sorry.
flimsy, okay.
Yeah. Most often what we'll see is they just list the facility. They may list the facility's administrator, the phone number, and the address. Sometimes there's a little bit of information, but you cannot, in my experience, ever get into finding out really what the staffing is, what the costs are going to be, or what the quality has been on any issues.
And I know that going back to your testimony, you mentioned the three recommendations. The first one was establish and implement national standards to promote quality, safety, and integrity in assisted living. The second was establish a national assisted living database. Is that what you're referring to?
Yes. Yeah. Similar to Care Compare, if I may, or there's Nursing Home Care Compare, Home Health Care Compare, Hospital Care Compare. On the Medicare website, there should be an assisted living compare.
Well, I think it's pretty fundamental that people should have the opportunity to place reliance upon a source that is objective and and to use your word, independent. I think that's true in any walk of life. Why would someone why should we settle for just relying upon assertions by those who are operating facilities? So I think that's pretty elementary, but we haven't reached that point yet in terms of a change in policy. I know I'm over time, but I'll turn to our Ranking Member Braun.
Thank you, Mr. Chairman. I want to start first. I want to ask Ms. Simpkins a question, but that idea of transparency and information, to me, I don't know how you could say that wouldn't be good. I've been a proponent since I've been here that this place ought to focus as much on that as anything, because we're a portal of information that if you collate it properly, that would seem to make sense. And I think that goes across the spectrum of healthcare as well. I've been the most vocal senator that our healthcare system is broken. We do not have transparency. We do not have competition. It's kind of almost like an unregulated utility, and you get your bill after you've had a significant healthcare scrape or a bad accident. You got to hold your breath to see how much it's going to cost, or you can afford it. So, like that idea. Mrs. Vessenmeyer, you mentioned that it was $7,200 a month, and it could have been more, and that's in Virginia, correct? Is that where the...
Yes, but that isn't the number that I gave you. That his room charge was $7,800 to start, actually $7,900 to start, and it cost me close to $13,000 a month.
$13,000 a month, okay.
That is correct.
That sounds unaffordable, so...
If he hadn't passed away rather quickly by the time, the length of time he was in there, it would have used up all of my nest egg.
That's the kind of stuff I've been appalled by from the time I took on healthcare reform in my own business 15, 16 years ago. How lucky the industry would tell you it's only going up 5 to 10% each year, in your healthcare premiums. Sooner or later, people can't afford it, and something's got to give. I was noticing in your background, Ms. Simpkins, you focus on low income because some people are going to be able to afford it despite the quality of care and the level, but most people will not. So in Indiana and the 4 other states where you operate, what would that range be per month as you'd compare it to $7,000 to $13,000 a month? And it seems like when it was all in, it was closer to that higher figure. Just curious.
Yeah, thank you, Ranking Member Braun. And the range that a resident or resident family would pay under the home and community-based services is really nothing. In Illinois, there's a small personal portion. It's based on resident income and allowing them to do things to still have money in their pocket. In Indiana, there's no personal portion, so the state of Indiana will pay for those services through the state.
So in your facilities, for low-income individuals, there's basically very little out of pocket?
There's very little out of pocket. There might be some personal portion based on what they actually receive in income, and it doesn't go over what anything a Social Security amount is.
And how much would you be able to generalize that across the rest of the country?
To model that program? Oh, you can model the program.
And are other states doing that?
There are other states that are doing it. Now, I will say that Illinois through the supportive living program in Indiana are probably, and Ohio are doing it really well, recognizing that there's a need within their state. There's an underserved population. There are people that cannot afford it. And so that's what we were founded for. That's our business model, is to say there's an unmet need and how we're going to do it. And we work with states that have the programs, Medicaid waiver programs in place, along with rate reimbursement that makes sense.
So, Mrs. Vessenmeyer, you would not have qualified for any low-income opportunities then. Is that what kept you into what seems to be outrageous in terms of the cost per month?
That's correct, because even
Okay.
though we were both retired, they look at all of your savings. And if you have a decent IRA out there, that counts.
So it begs the question then, is the low-income stratum across the country being served adequately? That almost would seem to be surprising to me if that were the case. But what we're seeing on the other side, then it's a question, there just wouldn't be many families that could afford it. And, I don't know what the criterion or the cutoff is. Can you fill me in a little bit? Because it sounds like in Indiana, especially if there are other options to choose from other than just your organization, that the low to maybe middle income strata are being served well. Is that a fair statement or not?
That's a fair statement, Ranking Member Braun.
And do you think that is the case across the country as well as you know, because you serve on some boards where I think you'd have that information?
It's not across the country. So nationally, there needs to be programs in each state to provide access to affordable assisted living, and they're not all there yet.
Generally, and that's at least a little bit surprising. And generally, it's the folks at the other end of the spectrum, the low and middle, especially low, that don't get adequate services. So I think that's something that you need to get those practices spread out to where we at least can get that in most other states. And then you got to tackle something like this that I don't know how wealthy you'd have to be able to afford that easily and for a long time. Something's got to give there. I'll rest with that right now, and I'll have another round of questions if we do it.
Thank you, Ranking Member Braun. Return next to Senator Kelly.
Thank you, Mr. Chairman, and thanks to all our witnesses for being here today. Mr. Mollett, the Arizona Republic, the paper of record in my state, published a series of investigative reports last year about the state of long-term care facilities in Arizona. And these journalists spent more than a year on this investigation. They reviewed police reports, they reviewed footage in some facilities, they analyzed regulatory reports from the state, and they interviewed families and experts. And what they found was, I think it's fair to say, horrifying. They reported graphic stories of a resident dying after being attacked by a roommate who hadn't received her medication in time. Another report of a assisted living resident being sexually assaulted by another resident, and incidents of violence among residents that often aren't reported because they aren't required to be reported under state law. And they highlighted the failure of state agencies to investigate these cases in a coherent, transparent way that would allow families looking for a safe place for their loved one to know that what really goes on in these facilities. And I think a lot of us knew there were issues in the system. We knew that, but I don't think we knew how bad it was. Since these articles were published, Arizona's governor has put together a strong legislative package to standardize inspections, promote transparency for residents and their families, and empower our adult protective services to investigate appropriately. And the state legislature is looking at proposals. So, Mr. Mollett, are these the type of steps that can help tackle these issues?
I believe so. I mean, of course, the details matter. These are very nuanced issues about caring for people with dementia, ensuring that things are reported appropriately, that there's good oversight. As much as possible, we would hope that a state would be looking to implement policies and practices that prevent bad things from happening, as well as, of course, ensuring that when they do happen, that they're rectified and that they're reported appropriately.
So Arizona can't be the only state that's facing these challenges.
Not at all.
So should the federal government maybe consider having a role here in providing oversight for assisted living facilities?
I think it's time for the federal government to step in. As I mentioned in my testimony, 40 years ago, when nursing homes were in crisis, Congress stepped in. Congress took that, initiated action, and we're here now with assisted living as well. The same population in terms of numbers of people are in assisted living as they are in nursing homes, but we don't know what's happening to them. We don't know the care they're receiving. A lot of it is private pay, not all of it, but there's unfortunately a lot of fraud.
So apparently more than 20 years ago, this committee helped to facilitate the creation of an assisted living work group, which was made up of 50 organizations. And this work group was tasked with coming up with recommendations for best practices in assisted living facilities to ensure a more consistent quality landscape across states. The result was a 380-page report with a lot of recommendations. And these were hard to agree upon. So, Mr. Mala, what has happened with these recommendations since this report was finished, if you're familiar with it?
I haven't read it in a long time, but I am familiar with it. Frankly, on the federal level, nothing has happened. So as Ms. Simpkins said, we do see some things going on in the states, but it's, generally speaking, the states are just not inclined, frankly, to take action on a lot of the work that they do. Hopefully they'll be different in Arizona, but it really is time, I believe, for the federal government to step in to ensure that wherever someone accesses dementia care, that means something. It's not just a term of art. And wherever they go for safety, they know that they can live safely. And wherever they are going into, they know what the expenses are going to be, that they're cognizable.
Well, thank you. I do want to note for my constituents a resource created by AARP Arizona and by the Arizona Republic following this investigative series that I mentioned. It's a backgrounder on long-term care, the definitions of different terms, what families should look for, and what questions to ask. And folks can find this on the AARP Arizona website, and my office will be posting this on our social media accounts, and I'm going to submit this for the record as well, Mr. Chairman. And I urge Arizonans or anybody else interested to check it out. And thank you.
Thank you, Senator Kelly, and that will be accepted for the record, not just submitted. Thanks very much, and we'll turn next to Senator Vance.
Thank you, Mr. Chairman, and thanks to you and the ranking member for hosting the committee hearing today, and welcome to our witnesses. Thank you for being here, and welcome to all of our guests. I want to direct my questions to you, Ms. Simpkins, and I appreciate you being here. I'm particularly concerned by some of the estimates that I've seen about labor shortages that are long-term care facilities, not just now. I know there's sort of an immediate problem of not enough people at some of our elderly care facilities. But I saw an estimate that by 2030, we will need, given, obviously people will retire, will drop out of the workforce, but then we also have changing demographics in this country. We're becoming older as a country. I read that we will need an additional 7 million long-term caregivers at these elder care facilities. That seems like a shocking estimate to me. It's hard to imagine how we could possibly hire effectively a million additional people per year at these facilities, given the already existing labor shortages. I'm curious if you think that estimate is within the reasonable range, and if it's not, like, how many more workers do we need over the next 5 to 10 years?
Thank you for the question, Senator Vance. I have not heard 7 million. I've heard 5 million, but I can certainly, I'd be interested in your information, and I'll follow up and send you the information I have. In my response to that, we got hit by the pandemic really hard. Healthcare workers left, and they are never coming back. They said this was hard and we're not going to do it, and we've had to recover. And assisted living has recovered pretty well. What we also need to do is we need to build for this aging, our workforce is aging out and our seniors are aging, and we're doubling and tripling numbers when we get to 2040 and 2050. And so having a really intense effort on what that means to both recruit and retain, and if you don't mind, I'd like to share just quickly what we're doing.
Sure.
From a recruitment standpoint, so that's how we recovered. We were able to get really creative. We looked at people and said, what do you need? What is it going to help your household? We knew we needed to increase wages, so even in an HCBS environment, you can have rate methodology that allows you to pay a living wage and higher than what a minimum wage is. And then we looked at retaining because, as people come into the assisted living and they stay because they are so passionate about it. And in honor of their passion, we need to create something for them. So what we do is from the first interview, we ask them what they envision 6 months from today, 1 year from today, 3 years from today. We want them to envision a future with us and at least a future with the assisted living industry. And then we have to meet that need by career pathing, career mapping, and what we've done a lot of that, and what we've realized through those interviews and people saying, this is my career path, is we also need a skill path. We need to provide them with the resources, whether it's through a nursing grant, is through additional education that we're reimbursing them for, additional training that they need. So if you're going to commit to working within this space in a workforce, you also need to create and having a workforce that's continuing to be passionate, make a living wage, and have the tools they need and the want to stay.
Got it. Appreciate that. And, one just additional thought here is, you hear about these cases of elopements at some of our elder care facilities, and they are mercifully rare. We have close to 1 million Americans in elder care facilities right now. You maybe 2,000 or so elopements happen per year. That's a small number, but I worry with increasing labor shortages whether that number goes up. And I've heard some suggestions that you could fill the labor shortage gap by expanding certain immigration programs, certain visa programs. And the one worry that I have there, of course, is that if you take a person caring for an elderly citizen, you want to make sure there's not a language barrier there, especially with people who are going through dementia, might be losing some of their cognitive capacity. So we really have to wrap our minds around this. I appreciate the work that you're doing on this, and I appreciate your answer to the question. But are you worried that we might see an increase in elopements over the next few years, or do you think not?
We need to plan for how our seniors are aging and the additional care needs. And we do that through person-centered planning. I believe Dr. Kraft Morgan mentioned that. Our person-centered care plans revolve around what a resident needs because, and to Patricia's point too, somebody can have the same diagnosis and their needs are completely different. And if you're not having person-centered plan for that individual, which is collaborative with their family, with their resident, as much as they can participate in it, with their caregivers, you're not going to have the best plan to keep them as safe and secure as you possibly can. On the immigration side, I would, there's an opportunity here with unused visas to at least start bringing, if you think about the workforce, start bringing in some healthcare workers. And Senator Vance, to your point, there are some markets within that we're within that have the residents who also have language barriers. So having staff who speak Spanish, we have staff who speak Polish, based on where the neighborhoods are.
Yeah. Thank you.
Yes.
Thank you, Mr. Chair.
Thank you, Senator Vance. Senator Ricketts.
Thank you, Mr. Chairman. And again, thank you to all of our folks here that are testifying. I appreciate you taking the time to help us out here today. I represent the great state of Nebraska. And in Nebraska, we have skilled nursing facilities and assisted living facilities that are scattered throughout our state. And it's incredibly important to take care of the some 20,000 people who require care in the 500 different facilities that we have. And they can get that care for about $3,875 a month. Anybody who is providing assisted living services in the state of Nebraska that has 4 or more residents is designated as an assisted living facility that is regulated by the state and it's licensed. While I was governor, I signed into law a Assisted Living Facility Act to update the standards and the requirements that we have for our assisted living facilities. They're just absolutely critical, especially in rural parts of Nebraska, and to be able to help take care of people. And we want to make sure that we continue to have that service for our folks. And Ms. Simpkins, as you know, assisted living facilities, as I mentioned, are regulated at the state level, which allows states flexibility to be able to be responsive to local consumer demands. Are there any states in particular that are doing an exceptionally good job that we can draw lessons from? States you say, hey, they've got some good programs or things that we should be adopting across the country?
Well, I can speak for the states in which we operate. Illinois, Indiana, and Ohio have exceptional programs. And with that, Senator Ricketts, one of the things we noted in reporting, all of those states will require reporting of any of the incidences that were talked about previously, which is very important.
Are there other characteristics, though, that you think has led, or some of the approaches that you say that these states are doing a good job? What are they doing right? What are the things that, so you mentioned the reporting, that's obviously an important factor. Are there other things they're doing that you say, hey, this is why they have such good systems?
This is why there's a good system, because we have access within a state, and a state that is where assisted living is regulated under the state, and I'm going to talk particularly about home and community-based service, access to the regulators, access to families, access to everybody who, you have this local model that can create and innovate and come up with best practices. And I'm a big proponent, let's share our best practices, because there is nothing proprietary when it comes to caring for a senior and caring for somebody. And that's what those states are doing well. My fear is, if you move those conversations further away, we'll no longer have those things. The states in which we serve, and I'll talk about Indiana specifically, the state program, Medicaid waiver program and regulations are really dynamic. They promote and encourage having a local model where there's collaboration and there's innovation. And that's where we come up with best practices. So that, I would say that that is also a model.
Great. Well, hey, thank you, because that actually leads into another question I have then. Last May, this committee held a hearing that highlighted the strained nursing home inspection system. And as you know, nursing homes are regulated at the federal level and are heavily regulated by the federal level. Anyway, so if assisted living facilities are subject to the same sort of one-size-fit-all federal type regulation, what can we do as lawmakers to ensure that assisted living facilities don't have the same sort of problems we're seeing in skilled nursing facilities? How do we protect that, what you talked about, that local model and best practices?
Well, from the state level, we encourage all of the states. So the things that we were talking about, if we even just talk about reporting and the reporting of those critical events, reporting those up through the federal government. Under the HCBS services, each state has really an obligation to report up in order to continue to have their federal funding. They also are well aware of the transparency that comes from and the opportunity. Once those things, the states report up, we have a transparency and the opportunity to see what home and community-based services are doing across the nation, and we'll have a window and more models that we can see, because I'm sure there's more states that are doing it well. I just can't speak to those today.
So, but getting back to the idea of, like, if you have the federal government that's regulating these things, how do we preserve that ability of local folks to be able to really tailor how they're doing the regulation to make sure that we're not pushing a one-size-fit-all answer?
You know, there's been, we need to, from our perspective, we need to tell our story much better. There are really good stories to tell from a state perspective on our home and community-based services, and we need to do a better job of talking about those stories and the things that are going on within the states, the innovation that has happened, the times providers have been asked to sit at a table before there's a rule change, and not just ask for comment, but sit face-to-face with somebody and say, if this rule changes, how does it impact the resident that you're caring for and your workforce who is caring for that resident?
Great, so that interaction with directly with the people who are doing the job
Yes.
before rule changes are made with the regulators, so that we don't have unintended consequences with regard to the rules that are made that will harm the care that's being delivered in assisted living facilities. Is that fair?
That's fair, Senator, and I like the way you put that. Thank you.
Great, thank you very much. Appreciate it. Thank you, Mr. Chairman.
Senator Ricketts, thank you, and we'll turn next to Senator Warnock.
Thank you so very much, Chair Casey. I would be remiss in this moment if I didn't just take a moment to remember the legacy of the late First Lady, Rosalind Carter, whom I was privileged to know and whose mission was to center and uplift our caregivers. Her extraordinary work demonstrates how a healthcare system that leaves so many drowning in caregiving costs most of us will one day face, is a healthcare system that falls short of its basic obligations. Dr. Morgan, in your experience as a gerontologist, how does the cost of assisted living burden seniors, their caregivers, and their families?
Well, the cost of assisted living is both financial and emotional and real for many Americans. We have a system where there's not access to assisted living. In some states, there are Medicare waivers that cover a larger portion of those who need it at the lower income. But there are also states that have virtually no waiver programs, so that the only people that can afford assisted living are those who have those significant financial resources. And so the middle tier of America tends to do things that I talked about in my testimony. They reduce their working hours. They set up these arrangements across families to pay for assisted living if that's what they can do. They bring in people who may not be trained to support their person living at home. They make these precarious work and family arrangements to be able to make it through whatever long-term care they have for their loved one. If they're lucky enough to get into assisted living, then they're still coming after work, and they're still bringing the incontinence supplies, and they're still bringing the snacks and engaging the residents. And it's another job on top of the job that they're trying to do if they're still working, if they're still able to work. And that is really important in young onset dementia as well, because in young onset dementia, these people are still earning, right? And they have young onset dementia, and then the families have very few options for thinking about their forward retirement, right? Retirement isn't what we end up doing. We end up mortgaging everything to do the care and to clean out our savings in order to support this person living with dementia who may not be able to be at home. A lot of the young onset dementias have the sorts of things that Patty was talking about with Lewy body dementia and frontotemporal dementia. We have a different course of the disease, and it's really difficult for people to care for those folks at home. And so even if they're able to afford assisted living for a time, they run out of resources. And then what do? And sometimes they can get into nursing home placement, and sometimes there's good nursing homes to go to, but not always. It's awfully precarious for many folks.
Well, thank you. Your experience with this underscores the ways in which this costs not only the families, but all of us. It has implications for our workforce and our economy, so we have to have long-range, comprehensive thinking about this. The chair has been a leader in this, and I'm happy to join him. I was happy in joining him to ASSET, the GAO, look into how federal health care affordability programs like Medicaid and Medicare, which you mentioned, interact with assisted living facilities, how we can do better there. And whether families choose an assisted living facility or in-home care, they need help meeting caregiving costs. The average cost of $4,500 a month, that's average cost. But you rightly point out the ways in which, for example, with early onset dementia, people's retirement funds are actually drained, just taking care of the individual. And so that's why I support efforts to lower caregiving costs for aging adults. It's a critical issue for our country. And I'll continue to work with my colleagues on this committee, informed by the expertise of people like all the folks on our panel, to improve access to long-term care for families across Georgia and across the country. Thank you so much for your work in this area.
Thank you.
Senator Warnock, thanks very much for your questions, and we'll now move a little bit out of order. We'll move to a second round as we're waiting for senators to ask their first round questions, some of whom are on their way. But I'll start, and I know Ranking Member Braun has some questions as well. Dr. Morgan, I'll turn back to you. Your testimony provided a helpful overview of the importance of well-trained staff in assisted living facilities. We heard that direct care staff can have as few as 6 or 8 hours of training only before beginning their care duties. They might be responsible in some cases for 20 or more residents. The constituent of mine that I mentioned earlier, Angela, said in part what she wrote to us, quote, when I mentioned my concerns about my father falling repeatedly, a facility head nurse said, quote, falls are just part of aging, unquote. I'd ask you, Dr. Morgan, are falls and other accidents in assisted living just part of aging, or are there procedures, strategies, rules that can be put in place to address the risks that older adults face?
Falls is a really important topic in aging. There are a lot of great tools that people can use. The National Institutes on Health has a great flyer on this topic, 6 tips to help prevent falls. Falls, it's about prevention. Educating AL staff on fall prevention is vital. There are plenty of environmental audits that can be made. And some ALs have this training in place, but certainly it's an important aspect of initial and ongoing training that the AL workforce should do. The other thing that's tricky about falls is that there's a fear of falling that has a real impact in whether you're going to fall, and a fear from families who are scared that their mom or dad are going to fall. And one of the things that my father would say to his patients is, if you don't use it, you lose it. And in aging, it's important to keep up with balance and balance exercises and keep with strength training and doing those sorts of activities. And certainly assisted living and other places could do that to really help with improving balance, because we know that balance is really important in terms of predicting mortality. And so if we think about it and we support falls prevention, that is what we can really make a difference. And that's also educating families that, you know, if you use your assisted devices, if you get up slowly, if you manage your medications, you make sense to really think about falls prevention, because a fall can really have an impact on the trajectory of aging for sure. And it's really important that long-term care take that seriously.
Doctor, thanks so much. I'm going to cut myself short here. I have a little bit of a jump ball between Ranking Member Braun's second round question and Senator Warren's first round question. I think I'll start with someone who's arriving, unless.
To the ranking member.
Thank you, Senator Warren.
That's very gracious. I'll actually yield back to you since you haven't done it. So I'll be here at the tail end.
All right, well, thank you both, and thank you for holding this hearing. I appreciate that we're having this hearing. I appreciate your leadership on ensuring quality care for seniors in assisted living facilities. This issue is not a new one for me. In July 2020, my office released the findings from the first national survey of COVID-19 in assisted living facilities, revealing that about 7,000 residents had died from COVID in just the first half of 2020. In many ways, the threat of COVID in assisted living facilities was just as serious as it was in nursing homes, but these facilities received little help and little attention. Now, before that, in 2018, I released the first ever national assessment of quality care issues in assisted living facilities, which was completed by the Government Accountability Office at my request. That report revealed that over 20,000 serious health and safety problems occurring at assisted living facilities in just 22 states, from physical assaults to medication errors to unexplained deaths. In the years since my office did that work, new studies have revealed additional problems in assisted living facilities. Mr. Mollett, you lead the Long-Term Care Community Coalition, which is dedicated to improving the quality and accountability of senior living facilities. Can you say a word about what kinds of threats seniors at assisted living facilities face and how serious the risk is?
Thank you. I think there are two major risks, and both of them are serious. First, due to the increasing needs and vulnerability of people who go to assisted living, the risk of harm has gone way up. People are vulnerable, people are depending upon assisted living for significant dementia care, et cetera, and we just don't know if they're getting it, and we often don't know when terrible things happen, as you noted from that GEO report, which was so important. Secondly, due to the increased sophistication of operators, we have private equity, we have real estate investment trusts that are circling around in this industry, the risk of financial exploitation has gone up tremendously in recent years.
You know, and your key word, we just don't know. These are serious problems that have been going on for years, but we hear so much less about what's going on in assisted living facilities than we do in other facilities like nursing homes. So, Mr. Mollett, why do you think assisted living facilities receive so much less attention than, say, nursing homes?
It's a really interesting question, if I may. I think that, you know, in the 70s and the 80s, we had some tremendous scandals in the nursing home world, and that led Congress to pay attention and finally to take action. And I think that's where we are with assisted living now, is that we're hearing more and more of these stories. The GAO reports from 1999 and the more recent report that you mentioned, Washington Post and Times reports that Senator Casey mentioned, local news reporting from around the country, over and over, we're seeing that these issues are coming up, and now is really the time to take action.
So with nursing homes, we put in federal standards on this, got more federal oversight, but assisted living facilities are governed by a patchwork of state laws without any meaningful federal oversight. And that means no national standards that assisted living facilities are expected to meet. That is particularly worrisome because private equity firms and real estate investment firms, REITs, have gone on a buying spree of senior and assisted living facilities. We know how their model works. Private equity comes in, strips the assets, cuts the staff, and sends the quality of care down the tubes. So, Mr. Mollett, your organization has looked carefully at the data, and you've heard from the residents of these facilities. When private equity comes into an assisted living facility and slashes jobs, what impact does that have on the residents?
Well, workers are the most important component of care in any setting, especially in nursing homes and assisted living. So that could be devastating for residents. But we know, I mean, unfortunately, as we don't have a lot of data directly on assisted living, we have some on senior care in general, and of course on nursing homes and other care settings. We know that when private equity comes in to a sector, they often pillage it.
Yeah. In other words, more people will suffer when private equity comes in. We need to do more here. At a minimum, the Biden administration should require additional reporting on problems at assisted living facilities. In fact, that is a priority recommendation from the 2018 GAO report. While CMS is making progress on implementing this recommendation, they should finalize it quickly. This has gone on long enough without oversight. And Congress must look at ways to improve accountability, transparency, and quality of care in assisted living facilities. So again, I want to say to the chair and to the ranking member, thank you for holding this hearing. And to the ranking member, thank you for graciously letting me do this. I'm trying to cover 2 hearings simultaneously. And I appreciate your letting me ask these questions. Thank you all for being here.
Thank you, Senator Warren, and Senator Braun is again ceding to a colleague, Senator Fetterman.
Thank you, Mr. Chairman. And again, a credit to my Senator Warren. That's outstanding questioning as well, too. Anyway, thank you. Ms. Simpkins, your website states that your company's operating margins are consistently among the top in the country. And I understand that your company manages upwards $700 million from the low-income housing tax credit program, and a majority of your residents rely on Medicaid through Medicaid waiver. So, Ms. Simpkins, is it fair to say that your company is viable because of government subsidies?
Thank you for that question, Senator Fetterman. It's viable for a few reasons. And because we do have investors. And we're grateful to those who want to invest in affordable assisted living across the country. Otherwise, we would not be providing to almost 6,000 seniors today who are in Medicaid waiver. We also need a viable business plan, and it needs to be a business plan. When I talk about on the website, when it talks about our margins as compared when you look at affordable housing across the continuum, and it's because of our investors that we're able to have margins that we continue to do like certified dementia practitioner training and give education reimbursements and look into different workforce opportunities. And the third thing that happens in a viable business is you have to have a service plan. You have to have a service plan that's going to, it's focused on quality outcomes, and it's focused on high resident satisfaction, and it's focused on high employee satisfaction. And what you'll see in our website, thank you for noticing that, because we're redoing our website, and I'll be glad to send you a link as soon as it's done, because we're going to start posting our quality outcomes and our resident and employee satisfaction results. And that should probably be in March, so I will send you a link.
No, yeah, of course, that would be grateful. And also true, I am glad that there are investors, and they are a critical part of it. But I think we're able to, it's safe to say that the subsidies from the government is also it's important too, right?
It's definitely important. So we need both to have a viable business.
And that's not a criticism or an attack. I'm just wanting to establish that.
Yep, understood.
But given the government's undeniable role in this, in your operations, why do you believe that a company should not be able to use federal dollars to make a profit? And I don't judge anyone, of course, or earning a profit. But if you are making that kind of a profit, but maintaining at the same time the federal care standard.
Thank you for the question, Senator. The federal funds go into the state, and the state then decides on what that program's going to look like and what it's going to be. The opportunity at the state level is that we can have conversations with our state regulators and improve upon practices, share best practices across the continuum. I know Senator Warren mentioned the 2020 report that she had on COVID, and we were part of that report, and our outcomes were really, you don't want anything to happen, but our outcomes are really good in comparison to others. And we relied heavily on the state regulators and the resources within the state to help coach and educate and resource and everything we needed to do. I don't believe it could have happened at the federal level, the amount of attention we were able to get from the state.
Sure, and I want to be very clear that if earlier, of course, that we count on other investors to allow you to operate, and I don't have an issue with you, generating a profit. I mean, that's one of the reasons why people are in this. And of course, it's in fact that's why it works, and I'm grateful that it is. And really, this line of questioning wasn't an attack or isn't anything other than just to establish that because we are partnering through that kind of subsidies, that we really, I think we should maintain those kinds of federal standards as well too. And because all of them they combine together to allow this to work and to provide that kind of a very important kind of a service. And that's really, would you agree with that?
They are providing a very important service. And Senator, I actually appreciate your line of questioning, because if we didn't have these kinds of discussions, and even differencing in opinion, opposing views and different views, that's where great ideas come from, and that's where improvement and evolution comes from. So I do appreciate your questioning today.
Okay, and thank you.
Thank you, Senator Fetterman. We'll now turn to Ranking Member Braun.
What we've just been hearing here is just what I like about a committee like this. You're hearing a broad array of viewpoints. Healthcare has been something I wrestled with long ago, in the whole spectrum from early childhood through when you're needing to look at how you're going to spend your last years. It's been cloaked behind closed doors. Large insurance companies and hospitals, where we spend most of our money on the way to maybe a nursing home, assisted living, or if you're lucky enough to live it out in your own abode. It's got to be swamped with transparency and to where we can see. Mrs. Vessenmeyer's story, how can something like that happen? And that was in Virginia, when we're hearing $3,800 a month in Nebraska. Every state's going to have a different cost of living, a different cost structure. But that idea, Mr. Mollet, of a transparency portal and at least some things that are going to make it easier to shine the light on issues that are out there. To me, when you're against that, you're just trying to hide something. And for instance, on the bigger picture, and this is an interesting combination of individuals, myself, Senator Sanders, Senator Grassley, Senator Smith, Senator Hickenlooper. That's 2 Republicans, 3 Democrats. I've been working on this since I've been in the Senate. Competition and transparency. If you want to be in the biggest part of our economy, healthcare, and especially at the tail end of our lives, be out there, be open. Ms. Simpkins, I was wondering, because you've done a good job, and like Senator Fetterman said, your payor is coming through either state, federal governments, and you're aimed at low income. What is your cost roughly to do what you're doing across those 5 states? Because we heard 3,800 here. I just asked my staff, so maybe closer to 4,500 in Indiana per month. What are you finding? You're servicing low income residents. What's that cost structure look like?
Thank you for the question, Ranking Member Braun. I'm trying to,
That would just mean in terms of you have a business.
yes.
Without giving any trade secrets away, what does it roughly cost in those states to provide a service? Your payor is mostly from government. In the case over here, didn't have that advantage, and you saw what happened. And that was in a state like Virginia, which I would have thought would have been maybe moderate on costs.
Yep. The thing I'm struggling with, and I certainly agree with the transparency. Those are things that we're going to be showing all the conversations here today of the cost of care, making sure there's no hidden fees. The expense side, what I'm struggling with is the expense side really depends on the state in which you're in. And I'd certainly be willing to.
Well, let's just pick Indiana then, to keep it simple.
Indiana.
And then what do you charge the governments that end up paying you mostly? I'm want to get an idea of what the variation is in cost across this country. Okay. And then that whoever's in any component of healthcare should be always willing to make it easy for us to understand. And on healthcare that leads up to assisted living or nursing homes, it's terrible. And in my own business, I tried to create healthcare consumers so you can actually manage your own well-being. And even when I attempted it, it wasn't easy, but we did it.
Okay, I thank you for the clarity. The cost of care, if we were looking at Indiana specifically, and I think the best gauge is probably in our operating margin, because the cost of care of insurance and workforce and the insurance costs have gone up 15-20%, and sometimes it's it's a little bit higher in a an
and you
urban
can give me
area
a
than rural.
range too.
I can give you a range. Yeah. So the operating margins are going to be roughly between like 20 and 28%. When everything's considered, that's also a debt load.
Well, that's operating margins. I'm talking about what the government ends up paying for per month.
I'd be glad to send that to you, Senator Braun.
But you can get that to me.
Yeah,
and
I don't have that. I don't have
belabor
the
the point,
exact-
but just the difficulty of this, and you guys are doing a good job by all standards. We've got to have transparency across the spectrum of healthcare. And when you get to the tail end of life, I think it's as important as it is along the way. And until the industry and everyone in healthcare embraces transparency and competition, don't be surprised if there's going to be more of an interest to show how to do it from the federal level. And I'm a believer that that generally isn't necessarily the solution. It can end up even costing more. But unless you at least embrace what's done in all other industries, which is make it easy for people that want to buy your services, know what it's going to cost, embrace competition, don't try to keep people out of the business. You're never going to find solutions in healthcare. It's now up to 20% of our GDP, and as recently as 3-4 decades ago, it was only 5% of our GDP. It's breaking the bank, even through the programs we offer here that elderly depend on, Medicare and Social Security on their retirement. Something's got to give.
Okay, I understand, Senator, and I will send you that information. It's not that I'm not willing to share it. I'm willing to share it wherever you want to share it. I just don't want to misspeak on what those numbers
And
are.
I respect that. Thank you. And thank the other panelists for enlightening us on this subject.
Thank you, Ranking Member Braun. We could spend a lot more hours, obviously, on these issues, so we're grateful for all of you helping us. I'll have a closing statement, and I'll turn to Ranking Member Braun, and then we'll wrap up. I know a vote is, if it hasn't started, is about to start. But as we heard today, assisted living facilities are right now a growing piece of the, the long-term care continuum, but more work is needed to ensure these facilities are quality facilities, that they're safe, and that costs are transparent and clear to families. As Ms. Vessemeyer stated in her testimony today, assisted living facilities must provide what older Americans need to be safe and to be healthy as they age. This hearing has demonstrated that assisted living facilities face similar challenges to other long-term care options, including maintaining a well-trained workforce, providing safety, high-quality services, and being affordable. Throughout my career, I've been working to improve care, to improve transparency and quality throughout the long-term care sector. We have a responsibility to make sure every American can age with dignity in a safe place of their choosing. That's why I've worked with my colleagues to expand access to home and community-based services, improve nursing home oversight, and strengthen the long-term care workforce. And now we're going to continue our work on assisted living. As this sector grows, we must work to provide similar protections and safeguards that are in place for residents and their families, as we've all strived to in the nursing home context. We also want to ensure that any facilities and corporate owners that violate the trust of American families are held accountable. I look forward to working with my colleagues to ensure everyone who needs long-term care has safe and accessible options. One way we'll do that is to determine what the costs of assisted living are to families and how federal dollars are being used. To ensure these funds are being used responsibly to pay for quality care, along with all of my Democratic Aging Committee colleagues, we've sent a letter to the Government Accountability Office asking them to conduct a study of assisted living costs and how available and transparent that information is to families. And as I said in my opening statement, I want to know more about what people are paying for assisted living and to have people tell their stories, as we heard some of the stories today. So again, we'll be asking people from across my home state as well as the country to share stories and to share your bills with us if you'd want to do that. We want to hear from you about the true cost of assisted living and understand whether families have the information that they need to make this difficult financial and healthcare decision for a family member and for the family. So I'll turn to Ranking Member Braun now for his closing remarks.
Thank you, Mr. Chairman, and thank you again to all the witnesses. This committee is unique in that you really can't craft legislation out of it. A lot of it, though, from this discussion happens through other committees, so always keep that in mind. We heard how critical it is that federal policies support the caregiving workforce. Senator Vance pointed that out back in Indiana. I mentioned how workforce in general has a lot to do with our school systems, making sure that they emphasize career and technical education along with four-year pathways, because not like across the country, maybe a third of jobs need the four-year degree, and we need a better high school education for many of these issues so you can hit the ground running. It should be policies from here, I think, should focus on boosting workforce. I think we all kind of agree on that. Many bills are out there to do that, and to make careers in healthcare easier to attain. Got to make sure you don't work at cross purposes, like some of the policies that are going through the labor agencies and that side of it that are wanting to make it harder for independent contractors, for individuals, where a lot of this assisted living help comes from. So want to make sure we don't work at cross purposes. We also heard how states and the providers themselves are doing things. Sadly, though, not all states seem to be doing it well, because you cannot have many instances of that and say that you got an industry that is working. That should be the rare exception, never the rule. And then when we're talking about how this place actually helps, when you're promoting transparency, it can bring odd partners together. I've seen that. Two ends of the spectrum, because no one should ever be against being able to have more information to make a good decision. When it comes to standards, I think that's important. Databases, that's all something we can do, share it with all the states. I think those are good ideas. I'm encouraged by the conversation we've had here today. That's how you get better ideas really good practices. This should be something, whoever's doing it the best, you need to shout it out so that the rest of the country can participate in it. Thank you again. Thank you, Mr. Chairman.
Thank you, Ranking Member Braun. I wanted to thank again our witnesses for contributing both their time and their expertise, and of course bringing your own personal stories, your own personal experience to this issue. If any senators have additional questions for the witnesses or statements to be added to the hearing record, the record will be kept open for 7 days until next Thursday, February the 1st. Thank you all for participating today. This concludes our hearing.